All right, we're back doing our video discussion lectures again. Today we're doing psych emergencies. All right, so really and truthfully, as far as psychological emergencies are considered or behavioral emergencies are considered, for you and what you need to know is you just kind of need to know some of the areas of what your patient might be experiencing. And so really, honestly, it's how to kind of just coax them and get them to basically go to the hospital and get some help, and for you to be able to stay safe and kind of have some of the warning signs of when an already bad situation is probably going to go worse for you. Basically, kind of give you some warning signs of when the patient might actually lash out and actually hurt themselves, try to hurt you. That's what we're looking for. And to give you some things about like excited delirium, what they call agitated delirium. But basically give you some of the warning signs and maybe some risk factors for that. You're going to deal with a behavioral crisis, but just because it's behavioral, just because they're not acting right, doesn't mean that it is just automatically a psych call. So there's some things that you need to be aware of. Some are like they may have an underlying pre-existing medical condition. There could be some mental illness that could be what's causing the behavioral emergency. But they could have done some mind-altering drugs. They could have done, LSD or Molly, or they're on meth, or they're drunk and they just got slurred speech. Also, some people don't react well to stress. Stress is going to be a big, huge factor in how people are feeling, especially like even in today's time. We're in this COVID-19 pandemic. People aren't working, and yes, they're getting a stimulus check, but $1,200 may not make it very far as a house payment, food, stuff like that. So people might be stressed. They might be feeling the pains of an emotional time. So you got to bear witness to that. So basically, when I say psych patient, what do you think? Most people typically think this. They think of a psych patient being crazy, or when you get called out to, you maybe have law enforcement on scene. Yeah, I'm plugging for you, Kazmar. That'll call out for a mental evaluation, and they're wanting to know that the patient is medically cleared to go to jail, basically. So you're going to get called out. There's going to be all sorts of things. You'll also be called out to possible what they call SI, which is suicidal ideations. Somebody that's having thoughts of suicides or wanting to hurt themselves. So those people wind up getting a code called a 1013. They usually it's done in the hospital. It's done by a doctor, and they get transported or usually taken to a psych facility. But the reality of it is that not everyone that has an emotional crisis or feels depressed or has some sort of psychological impairment is not sick. They're not something to be shunned. There's a huge stigmata that goes along with psychiatry and psychology. I don't know if you heard me say it before. It's kind of my passion for being in school. That's what I'm studying, and I will tell you that this chapter does not do it justice. But overall, like I said, you don't need to know everything. You just need to know the basics and what's going on, and how to keep yourself safe. So the defined behavioral emergency, basically that's a deviation from activities of daily living. We all have activities of daily living that has been deemed by society, by the society in which you live in, as normal. And it's when people start deviating from the quote-unquote normal is where we start having the issues that might be a behavioral emergency. Now, mind you, I said behavioral. Behavior has to do with the way a person acts in society. So you may have a person that's from somewhere else, another country, come in and not behave appropriately, when that's actually behavior that is appropriate for where they live. So there are also some cultural considerations as well that you've got to take into account that you may have to encounter and be aware of. But anything that interferes with activities of daily living is going to be considered a behavioral emergency. Notice it's not a psychological emergency; it's a behavioral emergency. So they do say 1 in 5 people usually have some sort of mental health issue within the past 12 months at any rolling calendar month. So we are in April 2020. So as of April 2019, that 1 in 5 people do have an episode, and that could be a myriad of things. It could be depression. That's a big one. Something usually happens, and you'll suffer for a little bit of depression. It's when it lingers on, that's when it becomes a problem. But just keep in mind, 1 in 5 people have this. So this is going to be very prevalent in what you do. Going out and serving the community, you are going to deal with mental illness. So again, I'm just wanting you to have the basis of the understanding of what's going on and how to judge a situation to keep yourself safe and keep it from going from bad to worse. So like we said before, there might be some pathophysiologic reasons for abnormal behavior. We're actually looking to figure out if there's something else that is making this person behave and differently or have a psychological emergency. So we're looking for the underlying conditions. We always don't assume that people are crazy or mentally ill or sick. We try to figure out what it is that is making them behave abnormally. They list some organic causes of behavioral emergencies. Hypoglycemia is a big one. Hypoglycemia is a stroke mimicker. It basically looks like someone's having a stroke, and it can. So usually you want to check for things like that. If you've got somebody that might be having a low SpO2 sat, put them on some oxygen. Check their blood glucose level. If they'll let you. Now, mind you, you've got to make sure that they're going to let you touch them and be able to do this. Also, exposure to heat and excessive cold. Those environmental emergencies. Those will actually change mental status on patients. So we want to be careful of that. We'll get to environmental emergencies, and you're going to find out that, like, heat stroke, that's a big one. That'll have somebody altered completely, and you'll find somebody, and you'll just notice that they're just sweat, or their clothes are wet, they're no longer sweating, and they're altered. So be wary of that. So if they've had a long exposure, now it doesn't take long either, especially in the cold. It does not take long. People will become slightly altered because they're just freezing to death. So be wary of that. We've also got they said environmental, and for in EMS we usually think of the weather, heat, cold, but they're talking about like sociologic environment. They're talking about people, loved ones, family, in and around. So you may have an incident where there's maybe a death in the family, and you have people grieving, or you might have emotional conflicts. That's a big one. You'll get called out to domestics all the time. And you'll wind up having to basically, you're not there to find out who did what. That's not your job. Your job is to treat the wounds that have been received by the patient or patients, because you may be treating both sides of the party. You and your partner might have to divide and conquer and kind of treat and figure out who needs to go to the hospital, if anybody does. You might just be out there dressing some wounds and basically putting a bandage, dressing, and they'll be signing refusals, and then more than likely somebody will be going to jail. But that there could be emotional. There can be psychological problems. There could be underlying psychological history. Maybe someone just stopped taking their medicine, which is very common in like depression, or especially in bipolar depression, which we'll talk about later. People will be taking their medications. They'll feel really good, and they think, I don't need this medication anymore. I'm good to go. I feel great. I don't need it. But what they don't realize is that the medication is what's made them feel great and even keeled, and they stop taking it, and then they slide right back. So there's that to consider. Also, trauma. They talk about trauma or a sudden illness that could also alter them. And I will tell you, especially with end-stage cancer stuff, that's going to really make people altered. They're not going to be themselves. So we need to make sure that it's not a behavioral or psychological emergency. But usually on scene or stuff like that, when you get out there, the family's going to know. And they're just basically calling you out there going, they're way worse today. I don't know what to do. They're not acting in their right minds like they usually are. They're usually really sharp and with it, and now they're not acting, and it usually means that there's been some sort of deterioration downhill from where they were to where they are now, and it's not going to be pleasant. They do talk about brain disease. I really think of like Parkinson's, dementia, things of that nature. And again, it's the same thing. They were fine one day, and now they've got to take a turn for the worse, and now you're having to deal with the repercussions of their new quote-unquote normal, because they were normal to the family members, but now they're not. So there's that. Obviously, big one. Behavioral and psych emergencies is going to be drug and alcohol. Absolutely. Like, those are mind-altering drugs. They're going to make people not behave correctly. I picked up several people just strung out on meth to the point where their body core temperature is like 103 degrees. They've taken and ingested so much meth over a small amount of time that they are now just, they're revved up, they're amped up, and they won't sit still, and you got to try to like chemically sedate them and physically restrain them. So it's bad juju. So obviously substance related causes. Now you come into functional disorders. So we had, before we had like organic reasons, but now we just have functional disorders. Now we have literally the etiology, which means the basically of how it works. We can't figure out why it's like this. Everything looks normal, everything looks okay, but they have some sort of breakdown somewhere, and it's in their actual brain itself, where we cannot actually like find anything physically wrong on maybe a CAT scan, but their line of thinking is irrational. It's not normal, what we would call normal, and they can't function typically in society. So these are where we're talking about the psychological emergencies. Behavioral does encompass things that of organic nature. Now you start getting into psych emergencies where what's being affected is the brain itself, and it's not functioning correctly. So that's where you dive into it. So your book, for some reason, decides to go ahead and jump right into scene safety, and really scene safety is paramount for these calls. I wish they would talk about it first, but they should have told you first what to look for and then showed you scene safety. But scene safety is paramount. We're going to get to what to look for when scene becomes unsafe. Primary survey. History. I know that's not under your primary survey, but your general impression is going to give it away. I mean, there's things to look for. Like I said, I don't know why it jumped right in the assessment. It did not want to go over the things that you should have been looking for, but history, when you're forming your general impression, your posture, obviously your scene, vocal activity under your general impression. Like, is this person's cursing at the top of their lungs? Their posture, are they clenched fists down by their sides? Physical activity, are they pacing back and forth? If you have somebody like that, it's going to be very, very hard to corral in. And you might be able to. Sometimes it actually just takes somebody just listening. Just listening to them is what makes them feel better. And sometimes you have to play into a little bit of what's going on. And what I mean by that is, you are not supposed to say that you agree with the patient, especially if they've got some sort of delusion, or they're having some sort of visual manifestation that you can't see. Like, you're sitting in the ambulance, and I've been in the back of an ambulance where someone says, "Oh my God, do you see the faces on top of the ambulance? Or do you see the faces up there?" And I had to say, "No, sir, I'm sorry, I don't see them, but, but what are you seeing?" And then, like, okay, well, reassure them, tell them, well, I promise you, I don't see them, so they may not be there. And of course, obviously, they see them, they're going to feel it's their imagination, that it's not their imagination. So you cannot feed into what they're seeing. You can be honest and say you don't see it, and you can try to be reassuring. Sometimes you have to kind of use that to your advantage. Like, oh, well, if you're seeing these faces, maybe we need to go to the hospital and have it looked at why you're seeing these faces. So, because really, honestly, sometimes the hardest thing to do is to try to convince them to go with you to the hospital, because they think they're normal. They think they're fine. but they're not. And you need to get them to a place where they can be evaluated, and not only evaluated, but get long-term psych care or short-term psych care, maybe some outpatient care, where the meds get adjusted or they get on medication, and they can start taking the medication that'll help them live a healthier life. I don't know why they wanted you to consider this, but airway and breathing, circulation, transport decision. Okay, yeah. So when you are talking to a patient and there's no real apparent distress as far as a medical condition, and you are talking to a behavioral person or a psych patient, kind of focus on the immediate problem, but don't let them take over the conversation. Don't let them be running the conversations. I'm not saying that you need to be belligerent. I'm not saying you need to be ugly, but sometimes you need to be stern and basically like, look, I understand that you see these things or this is what's going on for you, but look, this is what we need to do. Right now, you kind of don't have a choice. Hopefully law enforcement will be there and help you as well in getting that patient corralled in and doing what they need to do. Real big question that you need to ask patients: do you have any thoughts of hurting yourself or anyone else? That goes back to the SI and HI, which is suicidal ideations and homicidal ideations. You need to ask them, do you have any thoughts of hurting yourself or others? And if they answer yes, that's kind of an automatic, oh, here we go. We're going to the hospital for sure. Now we've got to go. So, and it's a double-edged sword because at our policy where I work, if you have suicidal ideation, it's an automatic trip to the ER for an evaluation. I've had couples fighting and arguing, and one said, you know what, I just ought to kill myself. And he or she is saying it out of spite. They're saying it to be mean. They're not saying it in the actual act that they actually want to hurt themselves. But if there's any kind of like text message or recording or eyewitnesses say, yeah, he said it or she said it, our protocol is too bad, so sad, you're going to the hospital now. We cannot leave you alone to your own faculties to let you go ahead and complete the act. So that's our protocol. Protocols are different everywhere, but take that in consideration. If you have somebody that says that, more than likely they're probably going to need to go to the ER and be evaluated. What is really helpful is sometimes you might be able to bring in friends and family, people that are recognized by the patient, and that you can use them to help you to get the patient to where they need to go. Sometimes you may not be in a patient's home. You actually might be out in the public somewhere, and you might be able to get them on the phone or get them to come down to where you are, hopefully very quickly. You don't want to wait like an hour or 30 minutes for somebody to get down there, but if they can be down there in like 5 or 10 minutes and the patient's not a harm to themselves or anyone else, then absolutely. So you might have to utilize family members to corral this patient in and get them to listen and be able to cooperate. Again, I go back, it says on here, actively listen and be supportive. Yes, you need to pay attention to the patient, because part of the problem too, with patients, especially like schizophrenics, they don't feel anyone's listening. And rightfully so, because, you know, these people are pretty much blabbering on about conspiracy theories and things like that. So irrational stuff. So that's why people aren't listening. But, you know, you need to actively listen. And sometimes you're just rolling your eyes inside of your head going, oh my God, you got to be kidding me. But at the same time, you do need to pay attention. There might be something that they give you that might help you figure out what the key root of the problem is. It says document the patient's intellectual function. Obviously, what you're really looking for is like, are they alert? Are they oriented? Are they aware of what's going on in and around them? So those are the things you want to keep a close eye on and figure out. Because what's going to be really bad is if you have a patient that's alert and oriented times 3, person, place, and time, an event, and they're refusing, yet it's very obvious that they do need help. Then you're really a conundrum. We'll kind of talk about that here in a little bit. Physical exam, basically you're still looking for the organic causes for the behavioral emergency. Just, if you can, obviously do your D-stick, do mental evaluation, kind of look them over, stuff like that. Interventions, obviously, make sure they work. That what you're doing is working. So communicate. So the one big one: give the receiving hospital advance warnings. When you have like a suicidal or homicidal patient, they have said, yes, I have SIHI, and have said, yeah, I want to hurt you, or I'm going to kill you, or I want to kill myself. You want to give the hospital that, and you can use the phrase SIHI because not a lot of people know what that means. So you can say, yeah, patients had thoughts of SI. And so that means they'll get ready and have somebody there because they cannot leave this patient alone. What happens is when you go into the ER, they will literally ask the patient to strip down, which they do most patients. So they'll put them in a gown, but they'll actually get this special little jumpsuit of some sort, depending on what hospital they'll use. But they'll give them like a little white jumpsuit or a little orange jumpsuit, something. They'll take their shoes and make them wear booties. Basically take away everything until the doc sees them and evaluates them and decides to release them or transfer them for treatment. So you basically, what they're looking for is to get rid of anything that they could have to hurt themselves with. So they lose everything. They don't get to keep their wallet, their purse, none of that. They could lose all personal effects. They go into a locker that's locked up by security, and they are basically held, quote unquote, for lack of a better phrase, they're kind of a prisoner. They're kind of on hold, and they don't have their rights until a doctor evaluates them and makes sure that they're functional, and they can go back out, back into society if there's nothing really truly wrong with them, or if they go to inpatient, outpatient clinic, stuff like that. The big deal for this, again, as I'm going to stress, is your safety. If it starts going south, if things start going south, they start yelling, throwing stuff, whatever, back out, get away. Make sure you've got two means of egress, which means two ways out. You always want to try to make sure you got two ways out and make sure in case one gets blocked, you've got the other. So if things start going bad, go ahead and start backing out. If you have the patient on your stretcher, kind of stay with them. If you have to lower the stretcher down to the ground because they're flailing around so they don't fall over, do that. You do want to try to, if you do have a patient that you are transporting and it is safe, someone needs to stay with the patient at all times. Don't ever leave the patient alone. Because, sometimes when you go in, you'll go give a report out at the nurse's station while your partner's cleaning up the stretcher. Don't do that. Do not leave the patient alone by themselves. Someone needs to stay with them at all times until you've turned care over and gotten that signature on your documentation that the receiving facility has accepted the patient. Once they've done that, it's on them. So they also say don't be judgmental and don't challenge the patient's personal space. Obviously, we're not going to be judgmental. The only way you're going to get any patient to trust you and to gain trust in you and let you provide care for them and get them to where they need to go to get treatment is if they can trust you. So being judgmental is going to make them not trust you at all. And you don't need to be all up in the patient's personal space. Let me just tell you, just from experience, you don't want to be in their personal space, especially if they are slightly violent. The closer you are to them, they're going to grab or they're going to swing. So let's avoid that. I take a real hands back, hands off approach with a patient. I won't start an IV on them unless they absolutely need it. If I do medications, it's IM. If it's possible to do IM medications. So just don't be all up in the space. I know it's kind of an oxymoron to say don't be in their space, and you're in the back of an ambulance that's probably like 10 by 8, like 80 square feet, by 5, which is like, 400 square cubic feet area of space that you can't really go anywhere. So again, just kind of stay back though. I usually like to sit in the CPR seat. With these patients, I will, and don't sit behind them in the captain's chair either. I usually sit on the bench far, far away from them. And I'll just kind of sit way back. So that's just some tidbits for you. All right, so we had gone and discussed beforehand your physical assessment and your assessment. But now we're going to get into the mood disorders and the anxiety, personality disorders. They say psychotic disorders, which is also called neurotic disorders. There's eating disorders. There's trauma related, as far as like post-traumatic stress and substance abuse. Those are all the types of mental disorders. They're broke down into those categories. Mood disorders. Basically, these are people whose mood is affected in some way, shape, or form negatively. Typically, what you're dealing with is two big ones: is depression and bipolar. Let me see. I think I have a slide on depression. There we go. Depression is characterized persistently by a depressed mood, and depression is defined as loss of interest in activities, and it's caused to the point where it causes impairment in your daily living. And it's okay to be depressed. Sometimes things happen. You get bummed out. Excuse me, Corona. And you're basically you're down for a few days. It's where it starts becoming consistent and persistent. Like it's not going away, and it's always here. So that's where it starts becoming depression. There's actually a book called the DSM-5 that has all the diagnoses of all the psychological behavioral disorders and the criteria that it has for that to meet that. I forget what depression is. I think it might be maybe 14 days. It could be 30 days of just a depressed mood and your loss of interest in activities. But that's what depression is. It's basically the point where people just have no interest. They don't want to move. They don't want to get up from where they are. They don't want to go outside, or they don't want to go to the store. They literally will lay in bed, or they'll sit on the couch and just not do anything. They have no drive, no initiative. Now, again, there are things to look for. We just did endocrine. One of the things that should be looked for by a doctor before any of these things are diagnosed for depression is check their thyroid. Thyroid will do that. If they have hypothyroidism, that'll happen. Again, there's an organic cause for that. So that's what should be checked first. Now we get into bipolar depression. There's type 1 and type 2. I really don't remember which one's what, but I know bipolar disorder is, by definition, is periods of high mania. And mania is just excitement and just super activity to where it's excessive. Could also be agitation, severe agitation, where the person's confrontational all the time for a little while, and then it's kind of like a roller coaster. So you'll have a peak high, and then you'll have the start to go down low, and that's where the depression comes in. They'll have a period of depression, and then they'll trough out, and then they'll kind of start peaking back up towards normalcy, and then they'll hit their manic state again. This typically is cyclical. Usually it's anywhere between, to do a full cycle, could be anywhere from 8 months to a year, maybe a year and a half. We're talking about long longevity. So sometimes it's very hard for people to figure out that they're living with someone that's bipolar because it takes so long, and there are periods of normalcy. So I think if there's any more slides now. Anxiety's next. But bipolar is basically, that's why they call it the bipolar 2 for bi, and polar opposite for personalities. So again, you'll have somebody that is just feeling normal. All of a sudden they'll go through this depression. They just can't move, just like a normal person would with depression, and it's very long lasting. And then they'll start feeling better, and then next thing you know, where it really becomes devastating is they'll be super agitated, super mad for several weeks. Or a month or so, and they're just always picking and fighting, and it just emotionally causes stress and strain on everyone else around them, and they can't understand why they're agitated or upset. Or it could be even on the flip side of that, where they're super excited about everything, and they're going to clean, and they're going to do this, and they'll have like a list of 1,200 things they want to get done, and they can't focus to get one thing done, let alone the 1,200. And unfortunately, my dad is like my father is by far textbook definition of bipolar. Looking back when I was a kid, and it was really sad that I was actually in paramedic school. We were talking about bipolar depression, and one of the caveats is like, hey, just because we're talking about these, don't self-diagnose yourself, or don't diagnose your ex-girlfriend as being crazy with one of these disorders or whatever. But I literally I sat there and listened, and went, oh my God, that's my dad. And so he would go through that. He would get all excited, and he would have this this vision and dream. Like I was 18. He wanted to walk the Appalachian Trail. Mind you, we lived in California. We were 3,000 miles away, and he wanted to fly out here and then walk 3,000 miles or 1,500 miles or however far. I mean, that's just crazy. But he went and he bought backpacks. He went and bought all sorts of stuff. And then I just remember the decline. Him coming back down off that manic high, and it's just he sold everything. He sold it for cheaper than when he bought it. And it was horrible. So that's just kind of the things that you need to look for, and it's just the ups and downs. And again, it's very, very long term. Now there is something called acute bipolar, which means it's very quick, but we're still talking days to weeks. We're not talking weeks to months. We're talking days to weeks. So we're talking maybe a 6-month cycle or a 4-month cycle. But that's even worse. Imagine. That's even worse. So, but that's what bipolar is. Anxiety disorders. There's several underneath types under anxiety disorders. You have the generalized anxiety. You have your OCD and your panic disorders. I don't think I talked about OCD, so I'm just going to talk about it really quickly here. Obsessive means to think about it. As far as this goes, for this definition, compulsive means you have to do it. It means you physically cannot rest until you've done it. So a lot of people like to say that, oh, I'm so OCD about this, and I get it. You have to do something or certain thing. That's not really OCD. That means, to me, the way I've seen it and what I've studied, if you have to make your bed every morning, that's fine. But if it's to the point where you cannot walk out the door, and you sat there and think to yourself, did I make my bed? Let me go look. Did I make my bed? Oh, okay. I don't remember. Let me go look. And then you go back and look, the bed's made, but you still take time to straighten it out. And where it becomes debilitating is you keep thinking, did I lock the door? And then you keep going back from your car to check the door as you're trying to leave. Did I lock the door? Or you're inside your home. Did I lock the door? And then that's the thing. You are obsessed with thoughts like that. That's where it becomes debilitating. So yeah, you can be, I guess, quote unquote OCD about something, but really, to me, that's just, you're a human being. You like structure, you like routine, you like things to be a certain way, and that is, by nature, is human. You want structure, routine. Again, I go back to this pandemic crisis we're in. There's a lot of people that don't have the structure and the routine that they're used to, and so it's very bothersome. I, unfortunately, the only thing that's really changed, it just feels like summer with the kids home for me. So to me, that's the only difference. I still go to work. I'm still on call. I still do lecturing and teaching you guys. So to me, it's the way we've conveyed the message of teaching is different, but to me, it's still the same. But some of you guys are probably sitting at home going, I got sent home because I'm not an essential job function. So now you don't have that structure routine. OCD is even worse. It's basically you have these thoughts creep in about a certain thing or certain things, and it becomes so debilitating because you can't actually go out the door and live your life because you keep thinking about them, and then the compulsion has to be to check it or to do it over and over again. Did I brush my teeth? Oh, I don't remember if I brushed my teeth. Well, let me brush my teeth again. And that's where it becomes disabling, and it's a disorder. I think we do talk about generalized anxiety. They call it neurotic disorder, which I really don't like. I don't like that. Neurotic is such a negative term. It makes people think that they're crazy, obviously. So really, it's just had to do with generalized anxiety and phobias and fears. Anxiety really, generalized anxiety is just basically people that are just have anxiety about everything. They just always worry about things, and it's not so much that it's obsessive, but it's a little much. But it really, generalized anxiety is about everything, and it doesn't they won't focus on one thing, where obsessive compulsive disorder people will focus on a set of things over and over and over again. Generalized anxiety is just people that worry a lot about everything. Especially right now, there's probably a lot of people that have controlled generalized anxiety in this pandemic that are freaking out. Oh my God, am I going to die? Oh, I don't want to get sick. Oh, do I have enough masks? Do I have this? Do I have that? And so there are a lot of people freaking out. So there's a lot of people with anxiety, and it is debilitating. There are people that just cannot function because they just live in so much fear. They just don't know which way to move to be able to handle that. So that's kind of what we have to deal with generalized anxieties. Phobias. Phobias are irrational fears and debilitating fears, mentally debilitating fears of a certain situation or an item. For instance, when I was in high school, we had a girl that was literally afraid of ketchup. I don't know what happened to her as a child or younger child, but like something along the way made her afraid of ketchup. And you could literally put a bottle of ketchup in front of her at the table and she would panic. She couldn't function. She couldn't think. And it was just debilitating for her. She just could not move forward from that. Like I said before, most of you guys heard me say I'm a little claustrophobic. I can actually think. I'm not debilitated, but I'm not comfortable either. So I don't like tight places. I don't like having that surrounding in and around me where I feel like I can't get up and move. So those are phobias. Now those phobias can lead to panic. Overwhelming feelings of fear and dread, and basically you actually will have physical manifestations. You'll start sweating, nausea. You may want to vomit. That's what happens. So panic attacks are just exacerbated panic. But it's an intense, debilitating fear that's triggered by your phobias usually, or it can be generalized panic. And there's just so much going on that people can have panic attacks. One of the things that they'll notice is that they'll hyperventilate. And if they're hyperventilating, they'll blow off a lot of CO2 and their hands will start cramping. They'll be like, oh, why are my hands cramping? Like, oh my God. And they're tingling, they're numb. And they'll go, tingling, they're numb. Now they're cramping. They just keep having the panic attack. So usually the best thing to do is try to talk them through it, try to get them to calm down, try to get them to focus on something that is good. But like if they are generalized anxiety disorder people, nothing's usually good. You usually have anxiety about everything. So now they're panicking and losing control, even worse. I'm sure a lot of people, like I said, in this pandemic have had issues because now they have their normal anxiety. Now you just added this global pandemic, which they cannot control in their lives, and now it probably exacerbated their panic or their anxiety. So that's what happens with a panic attack. Usually the call that you'll get is going to be a 21-year-old or 18-year-old or 24, 5, 6-year-old, chest pain, difficulty breathing. That's the call that you'll get. The first thing that I always think is, okay. Now, again, based on the call, if they're having a hard time breathing, give them oxygen. If there's chest pain, do an assessment. I use the cardiac monitor, make sure nothing's going on, and get a good history. Do you have a history of anxiety? Yes. Have you ever had a panic attack? Yes. Does it feel like this? Yes. Okay. Is this where we're at? So, again, so good history and baseline vitals is very, very essential. They do talk about PTSD. I remember I referred back to the DSM-5. It's the book of psychological disorders. Has a criteria that's needed to meet the diagnosis. PTSD. Everyone can have PTSD as far as not so much the actual diagnosis, but everyone's going to have a little bit of stress after some certain situations. Death of a family member, especially if it's witnessed by someone, especially if it is witnessed by a young someone, where they have nightmares and night terrors. Where it becomes an actual diagnosis is when it lasts for 30 days or more, consistent, consecutive days. That's where it becomes the actual diagnosis of PTSD. And you can have PTSD over anything, any sort of traumatic event. It could be a sexual molestation event. It could be like military. It could be you guys can have it when you go out in the field. You can run maybe a pediatric death, and it just kind of bothers you for a while. And if it stays for longer than 30 days with the recurrent nightmares or night terrors, then yeah, and you can't sleep, you can't eat. It just totally bothers you. That's why we always talk about in the very beginning of the year. Health and well-being of the EMT, and we talk about finding outlets to be able to talk to people and things like that. So But you might be dealing with people that do have PTSD. They may not even know they have PTSD over something. The mind is a very beautiful thing. It can actually hide and mask the events that have happened. So people can live with it and they don't even realize why they're having night terrors and stuff like that. They can't sleep. So it is very serious, very, very serious condition. But really, the true feelings for it also is helplessness, anxiety, and anger with fear. Sometimes it's anger and unknown anger or unknown fear. Like they don't know why they feel so scared of a certain situation. So there's always triggers for it too. Kind of with all the phobias and panic disorder, you're gonna have signs and symptoms like increased heart rate, which means their sympathetic nervous system is activated. Systolic BP's up, pupils are dilated, mental acuity is heightened, guilt, shame, paranoia, hostility, all sorts of stuff. They do talk about how to deal with returning combat veterans, and they kind of trigger this onto the PTSD because this is where it's been very prevalent, or at least the diagnosis for it was very prevalent, especially with people that are in the military, that have served, that have watched like friends die, or they've been under attack, or had like a bombing or an IUD or something like that. I'm not sure if I said that right, so if I messed it up, I apologize. I'm obviously not from the military, but really, truthfully, be respectful of all patients, not just combat veterans, but of all patients, and work on a good history. These are the personality disorders. The one that we're really going to talk to you about is going to be schizophrenia. But just know that these are all the personality disorders. In the event that you did care to want to look them up yourselves, you're more than welcome to. But schizophrenia is a very complex disease. It's usually found in early adulthood. So it's not like it's like the kid is schizophrenic in school, but usually winds up finding out in early adulthood. And as they become older, the symptoms and signs become more prevalent. And those symptoms and signs are delusions, there's hallucinations, there's lack of interest or pleasure. I usually call them my conspiracy theorists. These are the people that are truly lost in their own mind. They will see things, they will hear things, there will be people that they talk to that aren't there. The best schizophrenia movie that I can tell you to watch is called A Beautiful Mind. It's by Russell Crowe, plays, I forget the name of the man, but he's a brilliant mathematician. And he winds up creating these figments in his imagination to talk to. And they're people that aren't really there. And he thinks about and has delusions of these people and scenes and situations that don't exist. And it's just... It consumes him, and he has to fight a lifelong battle of how to figure out what's real and what's not. And that's where the schizophrenics come in. You can really recognize them by they have uncontrolled thoughts. Their mind seems to race wildly. They will jump from thing to thing. They'll have disorganized speech, as in... they will say things and then they'll stop, or they'll say things and, like I said, jump from one thing to another. There's no pattern of speech of what they're trying to convey for as far as the message that they're trying to convey. They won't have a daily activity routine. They usually live in very, very squalid homes, or they live with somebody that basically caretakes for them and always complains about how messy they are. They also have a difficult time concentrating at the task at hand. And like I said, in The Beautiful Mind, the man's a genius. And how he gets through that and is able to concentrate is he plays into this fantasy that he's in the CIA or FBI and he's looking for Soviet messages and stuff like that. But he's also able to, with that playing into it, he's able to do his daily routine, daily life. And that's how he balances his life. But the treatment for it is usually, again, it's lifelong. It's a lifelong treatment. Acute psychosis. This is a state where the person is delusional, out of touch with reality. And usually this is your schizophrenics. And they have this manic, acute, psychotic psychotic episode, or also known as psychotic breakdown. This is where they lose all touch of reality. They go over the edge, and they're bad to start with. But if they're medicated, most schizophrenics do very well. They can still function in life, and the issues that they have are very minor. It's when they start having these psychotic breakdowns, that's where things start going wrong. And usually, sometimes it's something that will tip it. Sometimes it is the mind-altering substances that will tip them. Intense stress. We all have stress in our lives, and it's all in how we deal with stress and how we get through our lives and function through the stress. But stress is a big, huge emotional factor in a lot of these psychological emergencies. Sometimes the episodes are brief, sometimes they're not. Usually you're called. I have dealt with psychosis before, and usually what winds up happening is we have to chemically sedate them. They're just so adamant, and they're not listening, and they become combative because you're interfering in their breakdown. Basically, you're stepping in, or you've now become part of their breakdown. So we usually have to chemically sedate them, which it's horrible, but it happens. So some of the things that I want you to start paying attention to is that's going to be key you in that something's going to go from bad to worse. Is like the hand clenching, the pacing, the garbled speech as far as like they're speaking and it's words, but it's not making sense. They're not making any patterns. Their eye movement, even if they're a clenched fish or just the ticking, twitching, like they're clenching and unclenching their hands, stuff like that. So what they do, your book gives you this called COAST map acronym. Consciousness, they talk about the level of consciousness. If they're altered, you may have a schizophrenic patient that doesn't have an actual level of consciousness altered, maybe just mental status, maybe. I mean, they're basically just not there. Orientation, they're not oriented to person, place, and time. They are not, their mind is not in where everyone else is. They are not alert to person, place, time, events, nothing. They would not be able to orientate themselves. Also, activity. Are they pacing? Are their hands flailing when they're talking? Like, they're doing this and that when they're talking. Is their speech, is it very fast? Is it making sense? If not, then you need to think about that. Their thoughts. Obviously, you're going to speak their thoughts. Or they'll tell you their thoughts of things, and they just won't make any sense. Memory, they'll probably have an issue with memory, trying to remember certain things, events, things that just happened. They were there, and maybe they were supposed to be a part of it, and they were, but maybe they just don't remember any of it because it's just not making any sense. They're not able to store those memories the way they should. Affect is the way you present yourself. If they're very flat-toned, zero facial expressions, their mood is flat. That's how you can know that there's probably something going to happen. Perception, their perception of things that are going on. They think that policemen and you are really aliens trying to come and kidnap them. Had that happen before too. So those are your triggers that you need to look for. Managing a psychotic patient is very difficult. It may actually take that you have to restrain them, whether it be pharmacologically, which is basically with drugs, or chemically restraining them, or basically having to restrain them yourself. You shouldn't jump straight to restraints. You should try to make simple directions. Say, hey, listen, this is what we're going to do. I need you to get in the ambulance for me, bud. Please, I really need you to. And if they're not even paying attention to you, and you try to say, hey, listen, I'm going to reach out, I'm going to grab you, I'm going to grab your arm and help you guide you over to the ambulance. And then if they start losing it, then okay. You guys, as far as being advanced, basics and advanced, you're not going to be able to do pharmacological techniques. We already talked kind of about SI. One of the things that we'll touch on real quick is people who threaten suicide never commit to it. There are some things that you need to pay attention to. If they've got a note written out, more than likely they planned on it. If they wind up doing some things, as in like giving away all their personal belongings or all their effects, and you notice that a lot of, like, if you come into their area where they live in their room or in their house, and a lot of stuff is gone because they gave it away, That should tell you. Most people don't tell people they're going to kill themselves. So that's kind of how I judge it. It's like if they're saying, oh, I'm going to kill myself, they probably are really more wanting help than they are actually wanting to commit suicide. Because most people, when they want to commit suicide, let me tell you, they don't tell anyone. They don't let anyone know. And usually people who do commit suicide are very considerate. They have a plan. They will go ahead and act on that plan. And again, they're not telling anyone. So, and like they'll go out in the woods or out into the grassy area, and they'll do the act because they know that finding them is going to be very emotional. So they may leave a note saying, "Hey, listen, I've done this. I'm sorry, I can't live anymore. Whatever. This is where my body will be. Please don't be the first person to come get it. Please call 911." Like I've seen that happen too, and it's crazy. And I don't mean that in a negative way. It's just like it's unbelievable. Agitated delirium. This is going to be where you probably have more of a combative patient. Excited delirium, where they're going to be mad and angry, and you're going to have to restrain these people. It says limit physical contact, but yeah, good luck with that. Somebody's going to have to put hands on these people and like put them in restraints because they are probably to the point where they are wanting to be violent, or they are actively violent, and it's uncontrollable. So you're going to have to do something to mitigate the situation and bring it under control. One of the things, though, before you do any of that, before you lay hands on anyone, is you've got to have the medical legal considerations. If they are alert and oriented to person, place, and time, you are in a bind. That's why I was talking about earlier about the protocols that we have. They state that if a person says they want to hurt themselves, that they have suicidal ideations, too bad, you're going to the hospital. And yet, they're alert and oriented times 4, person, place, and time, and event, that's where you start having issues. So then you might have to seek medical control. Say, hey doc, I've got this person, so they want to hurt themselves, and unfortunately the doc doesn't back you up. They say, yeah, bring them in. Well, okay, they're not wanting to come. How do you want me to? Do you want me to chemically restrain them or physically restrain them? And the doc will be like, neither. And now you're in a pickle. So now you got a patient that doesn't want to go. Doctor told you to bring them. Now what do you do? So you'll have to work through that. But again, so if they're mentally incapacitated, it usually implied consent. If they're in their right mind. If they're not in their right mind, yet they're still alert, or they're agitated and they're not able to answer basic questions, it's implied consent at that point. Had they been in their right mind, they would want help. So they might be like, hey, you're kidnapping me, you're doing this, okay, yeah, kinda, but at the same time, you can't answer my questions, man. And I've had to do that before. Like, look, we're going to the hospital. You cannot tell me person, place, time. You don't know who you are, or you don't know who the president of the United States is, which could be a common thing, but you don't know who this person is your family member. And, you can't answer my questions about what day it is. You just told me it was 1960 something. And, you don't even know where you are. You think we're in Hawaii. So, yeah, we're going. So, also contract medical control if there's some sort of variance that you need to ask about. Again, like I just pointed out, they have the right to refuse care. But you got to be real careful where you're at and what you're doing. And always, look, it's always better to transport these people. You don't want to feel bad that they have suicidal ideations and like, oh man, I'm just kidding. And then you let them go, and then they actually complete the act. And now family is suing your service. You see where I'm going with that? So like you want to go ahead and have them just go down and get evaluated. Because even if they said it like just out of anger, fighting with a loved one, typically a doc will pick that up and be like, okay, look, seriously, that's fine. All right. And they'll let them go. So talk about some restraints. Be careful when you do lay hands on these patients. You really want to call medical control for restraints, especially physical and chemical restraints. Because once you lay hands on a patient, you've done assault, and now laying hands on them, you've battered them. So, and then you're going to take them and put them in the back of your ambulance and not let them go, you've just falsely imprisoned them. Especially if they're alert and oriented times 4. So you need to be very, very careful about how you want to do this. There's a lot of gray area when it comes to psych patients and actually getting them to go when they are in their own right mind. When you go to take somebody down, you're going to need at least 4 or 5 people. You're going to need 1 for each limb and then 1 for the body and or head. So you need at least 5 people to take a person down, at least 4. And then there's you. So be very careful. And that's the end of our lecture, guys. I'll get this posted for you guys, and I'll talk to you later.